Welcome to the HQI stopping Sepsis in Virginia hospitals and nursing homes. My name is John and I'll be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you do have a question, press star then 1 on your touch-tone phone. Please note the conference is being recorded. And I will now turn the call over to Lisa Mark. Lisa, you may begin.
Thank you, John. Good morning and welcome to our webinar, Exploring the New Updated Long-Term Care Regulatory Process, what acute care providers need to know. Today's presentation is part of the Stopping Sepsis in Virginia Hospitals and Nursing Homes project. My name is Lisa Mark and I will be your host today. Please feel free to post any questions you may have in the chat section, and there will also be time at the end where we'll open the lines for questions. Today's objectives include recent regulatory changes for nursing homes, including focus on person-centered care, new regulations, and reassignment of regulatory categories with a new blended survey process. New regulations and guidance from the Centers for Medicare and Medicaid Services that directly intersect with admission, transfer, and discharge of nursing home residents. The impact of recent CMS changes on public reporting of nursing home quality initiatives, and the day-to-day impact of the new Medicaid managed care program for new facility residents. We always like to share with you the HQI and VHHA staff working on the Sepsis project, and our photos are presented here. And now I'd like to introduce you to our speaker today, Mary Childs. Mary is president of Childs Healthcare Consulting. Mary works with facility staff to implement systems that will enhance compliance with regulatory requirements and improve the facility's efficiency, effective resident care, and value. Mary, it's all yours.
Thank you so much, Lisa, and thank you for each of the participants today. I'm very happy to be here and to share a lot about the changes that are currently going on in the long-term care environment. So if we look at where long-term care has been for the last 25 years, it's been fairly stable. But this year we are experiencing the biggest change that we've had since the mid-1980s. What we want to do today is discuss some of those changes. The first change that we're going to look at are changing the federal regulations for condition of participation for both Medicare and Medicaid. And this applies to all nursing homes who accept Medicare or Medicaid payments. It applies to all residents who reside in a certified bed regardless of their payer source. We're also going to spend a few minutes looking at the new blended certification survey process that becomes effective November the 28th of this year. So not only do we have a new
Mary?
Mary's still connected. She may have muted her line by accident.
I'm sorry, and I did. I apologize. Let me start over. Thank you so much. So today we want to spend quite a few minutes talking about the changes that are going on in the long-term care environment in the state of Virginia, and some that are going on from a national perspective. The first change that we're going to spend some time talking about are changes in the federal regulations that affect all Medicare, Medicaid certified facilities. This means that these changes apply to all residents residing in a certified bed, regardless of that resident's payer source. Not only do we have multiple new regulations that we'll talk about in detail, we also have a brand new blended certification survey process from CMS that is having significant impact on the way that the surveys are being conducted in the state of Virginia. We also have changes with Virginia licensure inspections that will have an impact upon our nursing homes. And in addition to that, Medicaid is implementing something called the CCC Plus program, which is a managed care program that affects all the Medicaid residents residing in Virginia nursing homes. If you see the next to last bullet, you see the letters MDS. Minimum Data Set is a federally mandated assessment process that every nursing home has to complete assessments on residents at scheduled times, and we have new guidance that came out, new definitions that came out in respect to this, effective October 1 of this year. We also have new quality measures that are being publicly reported and how these measures are going to be impacted by these changes. So, Lisa, if you will change to the next page that says the MEGA rule. The MEGA rule is what we lovingly call all of these new federal certification rules and regulations. It actually has 3 different phases of implementation. The first phase was effective last November 28th. Phase 2 is effective this November 28th, and Phase 3 will become effective in November of 2019. The guidance for these are all found in the State Operations Manual in Appendix PP and Appendix P, and these encompass adding new F-tags, new regulations that are characterized by F-tags, reorganizing the current regulations, modifying the categories, etc. Appendix P will give us the definitions and the processes that will be applied to the new blended regulatory process for survey. Now, the interesting thing is, if you'll remember, I said that all of this becomes effective November the 28th. So on June the 30th, we got Appendix P, which has all of the regulations and the interpretive guidelines so that everybody would have a clear understanding of the intent of the regulation, what was expected by CMS. It included some guidance to surveyors about what to look for and how to cite deficiencies. However, we have yet to receive Appendix P, like in Paul, which is the specific process and criteria for completing the new survey process itself. In addition to that, there was one other major change in this SOM, and that has to do with the definition and what is classified as substandard quality of care. And I'll explain that a little bit more as we go along. So if we look at key areas of change, Lisa, if you would move to the next slide. There are several themes that are throughout all of this. The first theme is that it is indeed becoming a person-centered care, meaning that the resident is the center of locus. In fact, many facilities are interchanging person-centered for being person-directed. There are new regulations and expectations and processes associated with admission, transfer, and discharge, and several of these will also impact how care is coordinated and communicated with hospitals. We also have quality of life and quality of care. We'll talk a little bit more about those specific regulations in a few minutes. And there are many new expectations in terms of pharmacy services and the use of psychotropic medication, with psychotropic being a very broad term that would include both antipsychotic and psychoactive medication. So, Lisa, if we could go to the next slide, please. So the next slide talks about some additional changes that we have, and these changes is something that is related to a requirement called facility assessment. The facility assessment is a very comprehensive assessment that each facility is going to have to complete. It has three major components to it in which they have to dig down and examine the demographics of their residents, the demographics of the services that they provide, and evaluate whether or not they have all of the appropriate services, sufficient staff, competent staff, and resources needed to care for the residents that they plan to have in their facility. The next one has to do with sufficient and competent staffing. That's across the board for all departments, not just nursing. There are new regulations and expectations regarding behavioral health, and we know that that is a big concern, not only in the state of Virginia, but also a big concern for our nursing home residents, because we have so many residents that have mental health issues, but we also have a large percentage of our population that are caring for residents with some form or level of dementia. There are new regulations regarding quality assurance and performance improvement. We've always had a regulation for quality assurance. We now have regulations that have expanded that scope into talking about the performance improvement, and each nursing home will have to submit a written quality plan to the state as they are having their survey. And certainly one of focus for this particular group is infection control and antibiotic stewardship. So at this one, we're going to talk some more in detail, but what we will actually be having is moving in the direction of which the hospitals have been doing for many years now in terms of antibiotic stewardship. So Lisa, if we can go to the next page, let's talk a little bit about antibiotic stewardship and infection control. What this is requiring is that the facility have a system for preventing and identifying, reporting, investigating, and controlling infections. These items is found at FTAG 880, and it's very broad and has many components to it. One of the components that is different and new for both the nursing home environment and is going to create some challenges as we coordinate care with hospitals and other providers is a requirement that the isolation should be the least restrictive possible for the resident under the circumstances. So we certainly want to do all that is reasonable and appropriate for making sure that we have the appropriate steps for minimizing transmission of infection control. However, at the same time, we have to recognize and look and explore some workarounds for our residents who have dementia and look at residents who may have needs for longer-term isolation and how that isolation impacts their overall quality of life. So it's going to be a balancing act for us. If we move to the next page and we explore a little bit deeper about tag F880, we will see that there's also requirements for making sure we have systems for reporting incidents that are identified under the infection control program and that appropriate and timely actions are taken by the facility. The facility will also have to conduct an annual review of its infection control program and update that program if necessary. So that update is going to come in several fashions. It will have to look at and consider incidents and how the infections have changed over the past year for that particular facility, and we also will have to be keeping current with the CDC guidelines. There are specific expectations regarding policies and processes to handle, store, process, and transport laundry. Something even as simple as observing an aide walking down the hallway in which soil linen has not been bagged and is being held too close to their clothing is a common citation in some of our nursing homes. We also have to explore how infection control is impacted by the medication administration processes that we do. The regulations are very specific to make sure that we have good systems and processes regarding the use of needles and other sharp items, but oftentimes we see that infection control is breached simply by some of the day-to-day actions that are taken during a med pass. The pill is dropped. We forget to clean the glucometer after it has been used, and you put it back into the medication cart, etc. So as we look, at least if you go to the next slide, that is F881, you will see the word Antibiotic Stewardship Program. This is a new concept for nursing homes. Now, nursing homes have, for a long period of time, looked at antibiotic use, but not to the extent of the requirements of these new regulations. So many of the nursing homes are having to initiate an antibiotic stewardship program. It's going to require that there be facility leadership commitment to appropriate antibiotic use. And when we talk about facility leadership commitment, we're talking about that at multiple levels. From the corporate level, the medical director level, the attending physician level, nursing, and so forth. We have to have facility staff that can be accountable for promoting and overseeing the antibiotic stewardship program. It has to be something that can be maintained and something that requires a tremendous amount of coordination with the consulting pharmacy that provide services into the nursing home. And oftentimes those services are going to be expanded beyond simply doing a report at the quarterly QA meeting. It means that they're going to have to track measures of antibiotic use throughout the facility, and that they're going to have to analyze those measures and report any variances. All of this is going to require a significant amount of education throughout the staff at the nursing home, the attending physicians and the medical director, and last but not least, it's going to require a lot of education at the resident or the resident's representative level. As we begin to see more and more involvement of the resident, focusing on that person-centered directive of care, we're having more residents and family members involved in the decision-making. So while the physician or the nurse may think, Mom doesn't need that antibiotic for that particular symptom, I can treat it with something else, we are finding that residents and resident families are requesting that. So we're going to have to really spend some time and examine how we are going to convey appropriate antibiotic stewardship to residents and their representatives. So one of the things that we really have to look at is that antibiotic stewardship is a program. It has to include specific protocols, and we have to have systems in place to monitor the antibiotic use. So this is going to be something that, again, as I said, is a fairly significant change for the nursing home, but I'm hoping that in their coordination with hospitals that we can learn a lot about that process, apply it for the intent that it is designed, and also apply it in a way that is efficient and valuable to each of the nursing homes. As we begin to implement these, and Lisa, I'm still on slide number 13 at this point, to implement antibiotic protocols that address unnecessary and inappropriate antibiotic use. Hopefully we can see a reduction in adverse events, including the development of antibiotic-resistant organisms. And the nursing homes are already required to track infections by both site of the infection and the organism. If we move to slide 883, it's another of the infection regulations under the broad category. This one talks specifically about influenza and pneumococcal vaccinations. Nursing homes are required to follow the CDC guidelines for vaccinating. We're required to educate, to offer, and to administer these vaccinations unless it is contraindicated or refused by the resident. One of the new changes that came about is that the nursing facility can develop a policy, have it approved by the medical director, communicated to the attending physician, saying that this is their plan and their policy. Excuse me. And therefore, they do not have to receive a specific order for each of the residents. In addition to this, they are required to report the vaccination. Excuse me one moment. I'm so sorry, I got something caught in my throat. They're required to report the vaccination for both flu and pneumonia on the MDS assessment, and that assessment becomes part of the publicly reported quality measures. Lisa, if we could go to the slide that starts 690, Incontinence care, Catheter, UTI prevention. This is a separate regulation. It has several components. Lots of discussion about managing a resident's incontinence, promoting good toileting health and habits. Lots of discussion about indwelling catheter use, what is appropriate when it is not appropriate. Lots of discussion about prevention of UTIs. So one particular F-tag that has multiple components. In addition to this is another one of those components that is reported through the MDS and is publicly reported. So publicly reports include how many residents potentially have an unnecessary catheter and how many residents have had a UTI over a certain period of time. One of the changes that we just had was in the federal regulations. If we go to the next slide that starts with bacteria, is a new definition of bacteria that will need to be applied in the infection control tracking program. In addition to that, we have also had new coding instructions effective October 1 for how we code UTI on the MDS. So let's talk just a minute about certification surveys versus licensure inspections. Typically, in the state of Virginia, we have had these surveys conducted at the same time. Not required, but they have been able to do that. The certification survey, which is mandated by CMS, has to be conducted on an average of once a year for each certified nursing facility. And there are different types of surveys that they can do. They can do a standard or an annual, which is a very comprehensive and intensive survey. They can do a revisit, and that revisit is optional and mandated based upon scope and severity of some of the deficiency findings. If there is a complaint or a concern, they can come in and do a complaint survey or an abbreviated survey. And in addition to that, we also have some CMS-guided surveys that are called focused or pilot surveys. And in the past, these have been focused surveys to come in and validate the accuracy of the MDS, to look at dementia care, and we have also had some pilot surveys for infection control. All of those are the federally mandated ones. In addition to those, we have state requirements for something called the state licensure inspection. And this is where we get off sync a little bit in terms of timing, because the state regulations only require that they be completed every 2 years. So most often the surveyors would try to merge those together. However, this past July, they had a new state law, and it has to do with the timing of the state inspection. So we now have many facilities in which those two combined surveys cannot be conducted together. So some facilities are having a hybrid survey that is the state licensure survey, in which a representative from the Department of Health comes in, conducts an analysis of state-specific requirements, and then leaves. And then at another period of time, a team of surveyors from the Department of Health will come in and actually conduct a certification survey. That typically is done by a team, as I indicated, and it is typically done over several days. There are guidance within those guidelines as to the number of tasks that need to be done, number of records that have to be reviewed, and et cetera. So it varies in terms of the size of the team and the length of the review for each facility. If we go to the slide that talks about deficient findings, I want to spend just a few minutes on this. You've heard me talk a little bit about scope and severity. So for every deficiency that is found, the nursing homes are given, in essence, a report card. And that report card is the determination of how bad the deficiency is, both in terms of scope and severity. So if you will look at the rows that go across, you'll see A, B, and C. Those, it's kind of like when you're in school. The higher grades you get in the alphabet, the better you are. The further you go in the alphabet, the more opportunity that you have. So A, B, or C would mean that there was no actual harm and there was only minimal potential for harm. If you have to have a deficiency, that's the row that you want to be in. When you look at the row that is D, E, and F, there was no actual harm, but there was potential, more than minimal potential. You were lucky that the harm did not occur. When you go up to G, H, and I, there is actual harm, and harm can be physical harm or psychosocial harm. If you go to J, K, and L, it means that there is immediate jeopardy and something has to be immediately corrected. Now, in order to be classified as immediate jeopardy, there could be harm or there could be a significant risk or potential for harm. When you look at the when you look at the columns, you will see that there's one column for isolated, meaning it occurred once or twice or it was random. Look at the column that is patterned. It occurred on one unit, it occurred on one shift, et cetera. But there is more than a couple, and there is a pattern to where it occurred. If you look at the widespread, then it means that in most instances, the facility did not have a system or there was widespread lack of understanding of that particular system. So we take a deficient practice and we apply it to a regulation and say, was the intent of this regulation met? And if the answer is yes, you do not get a citation. If the intent of the regulation was not met, then you are subject to being assigned a deficiency. They also not only look at the regulation, but they apply something that is called a psychosocial harm grid, and it can make the difference between having a deficiency at a D level or having a deficiency at a J level. Now, in addition to that, if you look at this particular slide, you will see that there are some boxes that have little triangles in them. So there is a whole list of regulations that are subject to being classified as substandard quality of care. These regulations cross over many of the regulatory categories. Some of them are included in resident rights. There's some in abuse. There's some in quality of life, quality of care. But these are specific FTAGs or specific regulations that if they are cited at the scope and severity of any of those blocks that have those little triangles in, they will be classified as substandard quality of care. Now, if you have a deficiency that is cited as substandard quality of care, it has a significant impact upon the penalties and or the sanctions that are applied. So for any of the deficiencies, there is the potential for having some type of sanction or penalty applied. Some of those options that is determined by CMS, not at the state level, would include civil money penalty on a per instance basis or civil money penalty that is applied on a per day basis until the facility is found to be in substantial compliance. So it's not unheard of to hear of some of the civil money penalties that are being applied for a very lengthy period of time. One example I will share with you that is not infection control related, but a facility had a burn that occurred on a resident from some spilled coffee, and the burn occurred in June. The facility was surveyed the following February. When the facility got surveyed, they had a penalty that was applied on a per day basis up until the point that they were found in substantial compliance. So it went from June through a period of time in March. And these penalties are significant in terms of dollar amount and significant over a period of time. In addition, CMS can apply a penalty of denial of payment for new Medicare or Medicaid admissions. They can actually terminate a facility's ability to participate in the Medicare or Medicaid process, and that has been done in the state of Virginia. All of this information regarding these deficiencies are publicly reported and are available through Nursing Home Compare. So that leads us to the next slide, Lisa, that talks about publicly reported data. So you would go to Nursing Home Compare. We can search for any nursing home in the United States. All we have to do is know the name of the city or the state, and we can begin to search. We're going to find information regarding their 5-star report, and once we get that information, we can drill down and we can actually read a redacted copy of their survey health and life safety inspections, Staffing information is publicly reported and can be compared to other nursing homes. There's quality measures. We'll talk a little bit more about them that are publicly reported. And they have recently added a tab that you can actually go and look and see the amount of penalties that have been applied, financial penalties or other sanctions for this nursing home over a 3-year period of time. So there's not a lot of unknown about a nursing home. This particular website is also developed in layman's language, so the intent was to assist prospective applicants and their families in making appropriate and informed decisions regarding the nursing home. Lisa, if we can go to the next slide that talks about the Medicaid CCC Plus program. It's the next iteration of a managed care program by Medicaid for long-term recipients, long-term care recipients. It is mandatory. It is not an optional program for the entire state. The participants that are eligible for this program have to be eligible for both Medicare and Medicaid, so there may be some exceptions of residents in a facility that are only Medicaid eligible. There are 6 plans that were selected by Medicaid that are being offered throughout the state. Now, not every plan is available in every state region. There is lots of information. DMAS has done a really good job. Department of Medical Assistance Services has done a really good job in trying to keep current information available regarding this program on their website, and we've given you that website. Because this is a new program, they have staggered the rollout. You will see the state of Virginia. Tidewater was actually started in August of this year. We moved into Central Virginia in September. Charlottesville and the western part of the state is in the process of being transitioned in October. We'll see that November is scheduled for Roanoke, Allegheny, Southwest, November, Northern, and Winchester is for December. So at this point, everything is on schedule. There's been lots of opportunities for learning and sharing as these programs have transitioned. What this is really going to do is to add another care manager to the mix of people that are involved in making decisions regarding resident care, approving services, approving hospitalizations, approving home health, durable medical equipment, and so forth. Each of the 6 programs have a little bit of variance regarding what they cover and their authorization processes. If we could go to slide 22 that talks about MDS changes, we've talked a little bit about this, but there are mandatory assessment forms that have to be completed for all nursing home residents residing in a certified bed, again, regardless of the payment source. Along with that, there is a very structured time process that has to be adhered to based upon certain conditions that resident is having. This information is very comprehensive, and it is the same assessment used for every nursing home in the nation, and then is transmitted to the CMS database. If we go to the next slide, it's important that we really understand the criticality of having an accurate MDS assessment. Now, when MDS was started back in the 1990s, they were started with the intent of guiding care decisions for resident care. We collect this data, we're doing this assessment, therefore that data and that assessment analysis should lead us to making better care decisions. That intent is still there and has now been amplified more to focus on include multiple interviews in which the nursing facility staff has to solicit resident and or representative input. In addition to that, this same assessment tool has data elements that are used to determine payment for covered services. It also is used to calculate information directly for the public reports, the quality measures, and the 5-star reports that is available. And it is now being used in a different manner as we talk about the new blended survey focus, because much of the information is going to be used to select the residents that will be reviewed during the nursing home certification survey. So let's talk a little bit about the regulatory wrap-up, which is on the next slide. Nursing homes, as we've talked about, are in the midst of major changes. But I really believe that in spite of all these changes that are coming from many different angles and perspectives, there are some very positive goals and opportunities in place. The first is to look at how we can integrate and transition to a more person-centered or person-directed care, so that we're not just treating a diagnosis or a characteristic, but we're looking at that resident holistically, incorporating that resident's preferences and choices. Part of the new regulations has done a good job toward educating and bringing standards of care up to current standards. So we are expected to see some improved quality of care and a big focus on improving the quality of life for our residents that are in the nursing facility. We believe that the goal is to see improved regulatory compliance. This is going to take a little while as we transition with all of the new regulations and the changes, and as our state transitions into that new blended survey process. And last but not least, it is expected to ensure that the facilities receive appropriate reimbursement for the care and the services that they are providing for their residents. So I'm going to pause at this point and turn it back over to Lisa.
Mary, thank you. And before we get to the question and answer session, we just want to go over just a few quick things with you guys. The first thing is to remind you of the HQI Resource Center. So in the bottom of the screen, there is the email or the web address for that. It's a great place for no-cost quality improvement resources. If you want to access any of our past sepsis webinars, that's your go-to place. A really recent popular resource for the hospitals has been the Patient and Family Guide to Understanding Sepsis, and as well we have one for the nursing homes for resident family engagement. We also added a new tool. It's called a Sepsis Risk Evaluation Tool, and this is a great tool to use as a standalone tool or for a rounding tool. If you have a current sepsis risk evaluation tool in place, you can use this one to evaluate your tool, or if you don't have one in place, try this one. So again, that's from the Resource Center. We have some coinciding clinical topics for sepsis, such as antibiotic stewardship and infection prevention, the Resource Center, and as well for all your nursing homes out there working on your quality measures, please access practice and coding tip sheets on our Resource Center. We have a couple of save the dates for you, a data sharing call for nursing homes, and this should say and hospitals, so I apologize for that. So on Tuesday, November 21st at 11 a.m., please mark your calendars and look for an invite for a data sharing call for nursing homes and hospitals. And as well, we had our third cross-setting collaborative meeting for nursing homes and hospitals that will be held in the Lynchburg area on Friday, December 1st from 10 till 12. And that's an opportunity for nursing homes and hospitals to come together, understand each other's care settings, and prioritize some mutual topics to work on that will help reduce readmissions back and forth for sepsis, and as well as decrease mortality. So please mark those on your calendar, and please look for invites as well. Your Sepsis Project's contacts for the nursing home group, that would be me, Lisa Mark, and the Joyce Dayvault for the hospital contact. So please feel free to reach out to us on our phones or emails for any questions you may have. And just a couple of follow-up things for the nursing homes and the hospitals. For the participating nursing homes in the Sepsis Project, please be on the lookout for a couple of emails from me within the next week or so regarding where we are on our timeline of projects and some upcoming important events for that. And for hospitals, the physician webinar originally posted for October 31st has been postponed, and that will be rescheduled, so please look for some communication on that. And that ends our seminar, and thank you so much for joining. Operator, we're ready now for questions and answers.
Thank you. We'll now begin the question and answer session. If you do have a question, press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, press star then 1 on your touch-tone phone. At this time, I have no questions.
Thank you for joining our webinar.
Thank you, ladies and gentlemen. That concludes